My name is Daniel Nead. I am a clinical psychologist and the integrated health director at Malama EPL Health Center. We're an FQHC over on Maui, and we implemented a trauma-informed care program about 6 years ago, 6.5 years ago. And so what I wanted to talk about today was sort of the basic premise of kind of what trauma-informed care is, to give a very general overview of sort of the concepts, what it is, what it isn't, and maybe some things to think about if this is something that's popping up on your radar and wanted to pursue it more. So specifically, the things I wanted to cover today were to talk about, what is trauma. There's multiple definitions of that depending on who you ask and what context you're in. Look at the impact of trauma on brain development, especially trauma that is experienced in childhood or those early developmental years. Talk about some of the things that make an organization trauma informed and some things that, again, you can think about or maybe even put into practice to bring more of a trauma informed approach to the care that you provide. And then some just final tips, takeaways, questions. I will try to leave some time there in case anyone wants to chime in or clarify anything or anything else you want. To start off, I kind of like to remind people, because I've been kind of asked this a lot. They're like, yeah, but I don't do therapy. I'm not a behavioral health provider, and that's fine. This is not a clinical intervention. This is more of sort of a philosophy and approach to care. And so to kind of give the empowerment of, anyone can be trauma informed, anyone can provide trauma informed care, regardless of if you're the front desk or you're, a provider. This is something that everybody can do. It's not a specific intervention. So, as the quote says, you don't need to be a therapist to be therapeutic. There's a lot that we can do as healthcare providers, as people working in the healthcare system, to care for our patients and to care for kind of their needs, all different kinds of things. And this is just one of them. So what is trauma-informed care specifically? Since I'm going to be using that term a lot. Well, to break it down, let's talk about what is trauma. Trauma, kind of from the psychological definition, incorporates a few very specific elements. Predominantly, it's the idea of significant loss or harm, either to yourself or to somebody else, generally that you've witnessed or experienced. You can get what we call a kind of secondary traumatization from watching things on the news, and sort of being exposed to violence in media, perhaps. But that is a little bit of a different flavor than what we're talking about here. Trauma can be either a single traumatic event, maybe we think of a car accident or a natural disaster, or it can be something that is repeated over many years that may not have one specific event necessarily. So things that might be like neglect, homelessness, poverty would be things that we might consider chronic or repeated traumas. And kind of the main thing that makes something traumatic is the idea that it overwhelms the coping skills that we have at the time to be able to deal with what is happening. It doesn't mean we don't necessarily get through it. A lot of times we do get through it, and we may develop some coping skills that get us through that traumatic event. But a lot of times what happens is if we keep using those same coping skills in the long run, they end up usually causing more harm than good once that specific kind of traumatic or that specific acute event is over. So again, kind of just expanding our definition of what trauma can be outside of, I think, the things that we kind of traditionally think of trauma as being, it really does cover a wide variety of experiences, or it can cover a wide variety of experiences. Again, we all have experienced probably some type of trauma. That doesn't necessarily mean that we have post-traumatic stress or any sort of, long-standing effects from it. There's a lot of kind of variation to how people respond, and a lot of good research on why some people are may have higher impact of their kind of long-term response to trauma than other people. But just to kind of think about when you're thinking about the communities you work with the patients you're working with, um, you know, what types of traumatic events or things that may have been traumatic to them that they may have experienced or potentially be experiencing even, therapy. So to break it down a little bit again, I kind of touched on these, but we think of trauma in three different ways. We have acute traumas, which again are sort of those single events. They have a start and an end. So again, things like car accidents, perhaps being assaulted. Um, it's a lot more defined compared to something like a chronic type of trauma, which may not be as intense or as severe as an acute trauma, but it's still affecting someone over a long period of time. So again, that might be child abuse, that could be bullying, that could be witnessing domestic violence. A lot of times when I work with people, they have a history or a background that, of trauma in childhood. And I'll say, well, what was like the one big thing? Like, I don't know, there was a lot of them. They're like, hey, that's good information to know. That can have a very different effect on us psychologically and physiologically if we're exposed to sort of chronic stress than something that happened maybe one time and then was done and we were able to recover from it in a different way. And then we have what we call complex trauma. And complex trauma is when you've been exposed to multiple of those things at the same time. So a lot of times you'll have someone who may have some sort of chronic trauma or chronic stressor that they're experiencing, like poverty or homelessness, and then something acute happens on top of that. And you may have multiple acute events that happen over time as well. And so again, that kind of adds a different level of complexity and a different layer of how that trauma may manifest in the long term, how coping skills may or may not kind of react or help in those moments, and even what kind of coping skills are needed to get through something that is ongoing and chronic versus something that might be just a couple minutes long. We also want to talk about historical trauma. And historical trauma is the trauma that maybe doesn't happen to an individual, but is the trauma that happens to a community. This could be a geographic community, this could be a cultural community, a religious community. And this is important because this is the way that sometimes trauma embeds itself into culture. It becomes part of the stories and the customs of those communities. It can become what informs the beliefs about the world, about other groups, about the government, about the healthcare system. That's based on kind of these past stories that have been passed down through generations. It can also happen on a very genetic level if we're talking about things like epigenetics, and the ways that chronic stress can, physiologically change us and change the way that our body responds and kind of rebuilds itself, and then passing that on to the next generation, literally through our genetics. And then to think too about the fact that some historical trauma is the trauma that's happening right now. So when we think about war, when we think about things that are going on in the world, those are the things that will become someone else's historical trauma. So, it's all happening at once. And so we want to kind of think on it on these different levels because we want to be aware that it's all happening on these different levels. A lot of times, even when people themselves may not be realizing that it's happening on all of these different levels. So when someone is exposed to trauma or traumatic events or repeated traumatic events, what is it that happens? Well, there's a lot of things that happen, but one of the main things that happens is the effects on the brain, the nervous system, the limbic system, and again, kind of the body's and the brain's way of keeping us safe and keeping us alive. So there was kind of a sentinel study done in the late 90s through Kaiser, And you guys may know this, so I won't go into it too much, but essentially what they did was, because Kaiser is Kaiser and they have a giant EMR, which is also a giant database, what they did was they asked a bunch of their patients a whole bunch of questions. Had you experienced anything? It was like 50 or things. And what they during childhood, meaning before age 18. And what they found were that there was 10 events that has a significant negative predictor of health later in life. That included mood disorders, substance use, certain types of cancer, heart disease, obesity, pain, all kinds of stuff. And these were the 10 kind of what they call adverse childhood experience or adverse childhood events, that kind of abbreviated as ACEs for short. And this was a study of, they did it in San Diego, and it was commercially insured people. And it was like a couple 100,000 people. So it was a really large sample size. But what they found was that large numbers of people had experienced at least one of these events, like upwards of 50% of people. And so they were finding not only were these things very predictive of future health outcomes, they were also extremely common. And that research has really, those numbers have continued, even over the last 20 years. So in looking at the most recent research, this was from the Youth Risk Behavior Surveillance System, that was 2013 to 2021, and then the Morbidity and Mortality Weekly Report from the CDC from 2018. And what they found was that, again, very much still, most people, especially a lot of adolescents, had experienced at least one of those adverse events. And upwards of a quarter of adults, and they didn't. The report I had didn't have, only had adolescents 1 and 4, but a quarter of adults had experienced more than 3 of those events. So again, this is very much part of our community. It's part of the patients we care for. It's part of our own families, our own selves. So these are events that are very much prevalent, and the effects of trauma that are very much present in the world, really, as we know it, whether we realize it or not. And when we start thinking about the fact that these are very predictive of long-term health outcomes, then this is something that becomes even more important, because when we're trying to figure out how do we prevent poor health outcomes, the cause of health outcomes, if we're not looking at this kind of sociobiological factors that are contributing to people's health, in the way that we have thought about obesity or smoking or alcohol use, then we're really missing some of the core causes of these sort of poor outcomes that people have to suffer through later in life, that maybe they're not thinking back and would have no reason to think back that what's going on when they're 55 is maybe being directly or indirectly caused by something that happened when they were 5. So important for us to know, because as healthcare providers, this is sometimes the investigation, and the epidemiology that we have to do when we're figuring out how to best care for our patients. We also want to think of this on a kind of a neurological or neurobiological level. When we have kind of the triangle on the left, right, has sort of what we would call typical development, right? People that grow up with a sense of safety, a sense of predictability, a sense of stability, where kind of the brain is allocating resources, right, to keep us alive functionally. And it's like, okay, well, if things are good and things are safe, then I'm not worried about where my next meal is coming from, or if I'm going to have a safe place to sleep tonight, or if someone's going to hurt me. Then I don't need to allocate a lot to just staying alive, right? I can kind of budget more of my brain use for things like higher cognitive functioning, social emotional understanding and regulation, because I don't need a lot of resources put at these sort of basic fundamental keep me alive sort of systems. However, when we have developmental trauma, right? When we do have times in our life, especially in our younger years, when our brain and our body are still growing, and the world does not feel safe, or our caregivers do not feel safe, or the world is not predictable, the brain is going to reallocate those resources and say, well, if we don't know what's going to happen next, then we need to be ready so that we can stay alive. And so the brain actually reallocates or allocates those resources very differently in that there's a lot more functioning of the brain and development of the brain in the areas that are more responsive and more reactive to the world around us. So you see much more, even like to the point like larger amygdalas, larger hippocampus, um, different limbic responses, um, because the brain has kind of been trained or trained itself to say we need these things to stay alive, so we're going to budget more energy and more development to those systems, because if we don't, we might not live to grow up. So like on a very fundamental level, trauma affects us with how we function, kind of not only psychologically and sociologically, but it's literally affecting us biologically as well. And we've seen that, again, even on like a neurological level, right? So the scan on the left is again what we would consider sort of like the typical, these were children, I think these were children or adolescents. But it's kind of the who had no real risk factors from growing up, kind of no identified issues, kind of the control group essentially. The scan on the right is from children that grew up in an orphanage, where they did not have the same stability, they did not have the same amount of attention, they did not have the same kind of stimulation that we would typically expect of a child. And so what you can see is there's significant difference in just poor brain functioning. So you can see the temporal lobes kind of over there on the sides that do a lot of, language and memory processing, higher activation for kind of memory integration with events. There's a lot less activation there. There's a lot less activation in the prefrontal cortex, right? Those higher reasoning, impulse control, kind of higher thinking that happens because so much more resource was put into just sort of staying alive. So you can see kind of in the back the occipital lobe, right, which is going to be responsible for scanning your environment and making sure things are safe, right, is much, much more active. And that's where we get into things like hypervigilance. We get into things like kind of those very high startle responses that people may have that can be actually kind of happening on a biological level as the body was growing up and adapting to its environment, finding ways to keep that person safe. So kind of, again, the idea that this is something that can be learned, that is absolutely psychological, but is also happening on a very physiological and very biological level as well. So what does a non-traumatic worldview look like, right? A lot of times what we're talking about with that is the world is predictable, right? I can understand it. I can process what's going on around me. I'm not getting overwhelmed by kind of just what's happening to try to make sense of it and try to get through the moment. A non-traumatic worldview allows me to focus on myself and focus on others. It allows me to understand nuance of language, of behavior, of situations, because I have the time and I have the cognitive resources to be able to really process what's going on around me and understand it rather than just trying to get through it. So, again, a non-traumatic worldview tells us about the world around us. It tells us about our place in the world, our worth in the world. It tells us about ourselves, like I can trust myself to make decisions. I'm good enough to get through this. I'm able to overcome the things that I need to, maybe because I've had the experience of doing that, because I haven't been in situations where it was kind of a lose-lose. Um, so it really sets up the way we see the world, the way we see other people, and the way we see ourselves. This can be very much contrasted with someone who maybe grew up with a very traumatic environment and so learned from that environment that the world is unpredictable. Like, I don't know what's coming next. I need to be ready. I don't know if things are going to be safe. Um, I can't depend on other people to help me all the time, or maybe at all. Or the people that are supposed to protect me are the people who are hurting. So I can trust myself. You know, this again really defines how we see, how we interact with the world, how we interpret other people's behaviors, how we interpret our own sense of self and our own being. It's really is the lens through which we experience reality. And so if my lens has been formed through, you know, childhood trauma or multiple childhood traumatic events, then my lens is really going to perhaps distort the things that I see around me, because that's what made sense to me growing up. Um, and so that's how I'm going to continue to see the world as I go forward. So what I'd like you to do right now is take a moment and think about a time when you were maybe experienced some kind of trauma on some level, or just got very activated, shall we say. Um, you know, the time kind of when maybe you felt overwhelmed by the situation or your emotions or the unpredictability of something. And just take a moment and think about what were the thoughts that you were having in that moment. What emotions were you feeling? If you remember, were you having any physical sensations at the time? Were you doing anything? Were there any behaviors that you were doing to help kind of get through that situation, or that you just realized you were doing out of habit or out of routine or just kind of reflexively? And just kind of think on those for a moment, and then we'll kind of use that to move forward. So your thoughts, your emotions, your physical sensations, your behaviors. How many people had any of these, some of these, all of these, in that example, or that situation that you thought of? Probably most of us, right? Um, a lot of these things we could think of are purely our limbic fight or flight response, you know. Um, but these are also a lot of times very normal reactions to very abnormal situations, right? We might find ourselves in a situation we didn't expect to be in, or didn't want to be in, or don't know how to be in. And our brain and our body is going to find ways to get through that situation as best it can with the knowledge and the experience that it has available, right? So, we've all probably been in a situation where we've experienced these symptoms, but we've had these experiences ourselves. So if we think of those or these symptoms not as necessarily problems, but as coping skills, right? That we used ourselves to get through a situation. And we don't think of these as bad things. We think of these as protective things or responsive things, or kind of just the learned ways that I had in that moment, or that my body did to keep me safe and get me through that situation. Does that change the way we look at those difficult patients who may be exhibiting a lot of those same symptoms or same problems when they maybe come see us? What if that's not them being difficult? What if that's them having a trauma response? And doing their own coping and using the resources and the knowledge and the experiences that they have as best they can to get through a situation that they're feeling very activated in for whatever reason. And so that kind of, in most ways, is the kind of fundamental idea of what trauma-informed care is, right? It's shifting from this idea of what's wrong with a person, and we've all said that, right? Well, you know, um, that has them acting the way they are, acting out, however we want to phrase that, and instead saying, okay, what happened to this person that they're reacting in this way, right? That's the core idea of trauma-informed care, right? It's a reframing of kind of maybe what we would consider negative or problem behaviors in ourselves, maybe in our coworkers, our patients, and trying to just reframe that and saying, okay, if this person's doing their best with the tools that they have to get through whatever it is that's happening right now, what, and we don't have to even answer that question. What if something, we can just say, like, maybe something happened and they're just getting through this the best they can. That really can change the way that we then approach the situation if we're coming at it from a place of this person's doing the best they can. They're not trying to be difficult. They're not trying to be mean. They might be mean and demanding, but this might just be the only way they know to get their needs met. That can really change the way that we approach a situation and help the patient in that moment if we can come at it from a bit of a place of more calm, and again, a place that's more trauma informed and understanding, okay, this might be a trauma response. Let me see what I can do with this. And that's why trauma informed care is not an intervention, right? It's a philosophy, it's an organizational structure, it's a treatment framework, of how we want to kind of understand and recognize and then respond to trauma. Again, the trauma that's already present in most things that we do, because trauma is present in most people's lives, right? 60% of adults and 80% of adolescents had experienced at least one adverse childhood event. And those are just childhood events, right? That's not even saying from 18 on, life continues to happen, So trauma is present everywhere we go. The more we're aware of it, the more we can then respond to it rather than react to it sometimes with our own trauma responses. So what does that mean then to be a trauma-informed organization, right? I've been talking about sort of this person and what trauma might look like in an individual. Well, then how is an organization to be kind of trauma-informed? What does that mean? Well, let's start with why medical settings might be traumatic for people. We have a thing called white coat hypertension for a reason. It's a phenomenon for a reason. And there's lots of reasons that people avoid going to the doctor, right? There's lots of reasons that people don't like coming to the doctor even when they do come. It's because coming to see a healthcare provider is a big vulnerability, right? It's asking for help. It's saying, I can't help myself and I need to depend on somebody else. And for people that might have, an interpersonal history of trauma, that can be very triggering to have to admit that I can't help myself and I need to be dependent on somebody else. It sets up a huge power dynamic of the moment they walk in the door, they're already needing something that they can't get themselves, that they're going to depend on us to provide for them. It's also can be a lot more kind of literal, right? It's physical touching. It's just derobing. It's, having to have a level of intimacy, whether that's physical intimacy, emotional intimacy, sharing of intimate information, with someone you may or may not know very well and may or may not trust. And that can be really hard for people to let down those boundaries and be vulnerable with anybody, certainly with someone they may not know well. Um, and knowing that they have to do that can be very uncomfortable. So um, doctors' offices in medical settings, can be really distressing to people for a number of different reasons. And so one of the first things that kind of was talked about with trauma-informed care is the idea of using universal trauma precautions, right? We have universal bloodborne precautions for a reason. Let's just use that same framework, and we're just going to assume everyone that walks in the door has some kind of trauma history. And then we know we'll hit everybody, right? We'll make sure we're treating everyone that might have a trauma history with the care and compassion that they need. And maybe people that don't have a trauma history are just having a nice time then. But that's sort of a very basic way of just saying, like, let's just assume everyone has some level of trauma. And so that's why we're going to kind of set up our organization and our policies and our responses and our care to just incorporate that with everything. We can also provide education on the effects of trauma. People, again, might be having a really hard time losing weight or getting good sleep or not understanding why they can't get their blood pressure down. To kind of ask some of these questions sometimes and say, like, hey, people that have experienced a lot of hardship in childhood or that maybe have had experienced abuse or neglect or things actually can have a hard time controlling their weight or their blood pressure or their A1C because of kind of how their body adapted to that. Is that something that might be relevant to you? It can take a lot of onus off the patient that they always feel like they're doing something wrong because they're not getting better, when it may not be anything that they're are or aren't doing right now. It may go back to that kind of biological adaptation their body did as they were growing up that is now having that sort of long-term negative effect. And so to be able to start that conversation or provide that context sometimes can help people go like, oh yeah, I had like that my whole childhood was like that might explain why my blood pressure's so high now. And it's like, yeah, oh, okay. It opens up a whole other way of kind of addressing a concern where no one's feeling blamed, no one's feeling judged, no one's feeling like they're failing. Providers as well, right? When you have those patients, you're like, this should work. Like I'm doing all the protocols. Why aren't they getting better? It can be very defeating for the provider as well. So to kind of come at these things and recognize these long-term links between what happened early in life to what's going on in, kind of adulthood, can really sort of take the pressure off both the patient and the provider when you're not getting outcomes that you expect. You can also use a lot of open-ended questions. You don't have to take like a trauma history from people. You can ask something, like, have you had any negative, I use this one a lot, like, are there any negative experiences from your past that you feel like are still affecting you or still affecting your health today? And they get to choose yes or no. Maybe they are identifying the thing and maybe they're not. But I can ask that question and kind of see what comes up. Again, patients may also not want to tell me things. I do a lot of like one-time consults in primary care. This person met me 90 seconds ago, potentially. They don't necessarily want to tell me all of their stuff, and that's fine. Again, it's kind of giving them control back, letting them kind of direct the conversation a little bit of saying, where is your boundary and what do you want to talk about? But at least by saying, giving the context of, we know that early experiences can have long-term effects even in adulthood on health. Is that relevant to you? I'm giving them the information of like, hey, this might be a thing. And even if they go, oh, no, I don't have anything, they now know that, oh, wait, that might be a thing. And maybe the next visit, they decide, hey, last time I was here, you said that thing about early stuff could affect. Can you tell me more about that? It might just sort of help get some of that conversation started, even if it's not happening in that one exact visit. When we get those trauma responses or when our patients are having those trauma responses, the other thing, kind of one of the things we also want to make sure we're doing is not re-traumatizing, right? Again, medical offices, it's a power dynamic. It's vulnerability of information, of physical touch, of all kinds of things. So people can get very activated very quickly, even when they realize it. And activation can be like kind of what we would consider, like kind of hyped up, angry, anxious, blood pressure's up. It can also be sort of the opposite, right? Fight or flight. The flight could look very much like sort of shutting down, being quiet, not really talking, not really engaging too much. That's also a trauma response, right? Stay small, stay quiet, and no one will notice me. So we want to kind of recognize, these things when we see either of those responses, that we're not re-traumatizing people since we're sort of in the position of power in the situation. So whatever is going on, kind of remembering to stay calm yourself, right? Even when you're maybe having your own response, which we all do because we're all human beings. Um, you know, I tell like my medical providers, if you walk in the room and the patient's already mad about something, you can't fix it because you didn't cause it, because it was already going on before you got there. So at that point is don't make it worse, right? But don't take it on either, because even though they might be directing it at you, if you didn't cause it, it's not your fault, So that can sometimes help people stay calm of just because someone's sort of throwing something at you doesn't mean you have to touch it. However, you can still validate people's reality, like kind of validate their experience. I can see you're really upset. I can see you're really frustrated. I can see you look really, really kind of anxious right now. Is there something we can do to help you feel better? We can kind of uphold boundaries, right? Not only respecting patients' boundaries, but drawing boundaries for ourselves, and the patient sometimes as well, but nicely. So, saying things like, if a patient's getting very loud or, getting, kind of verbally inappropriate, you can say something like, hey, in our office, we don't talk to each other that way. So I'm going to have to ask you to kind of lower your volume and use some kinder language, or we may have to end our visit early, right? And being very clear, I'm saying this behavior needs to change, but I'm doing it in a very nice, very non-judgmental, very non-blamey way. And I'm giving a very clear expectation to the patient. Here's what I need from you. And if we don't get that, here's the consequence that's going to happen, right? Very clear, very straightforward, and it gives them back the control. If you want to keep talking to me like that, you can do that. And we're going to reschedule for a different day. Choice that you made, right? So being trauma informed and recognizing trauma responses isn't about letting people get away with whatever. It's still about having boundaries and sometimes needing to draw boundaries where patients aren't able to draw them themselves, but doing so in a nice, very clear way. And then also for ourselves, taking care of ourselves on a regular basis, right? We can't show up and do this work and be there for our patients and sort of contain them and their reactions when they may need us to for a little bit if we're coming in kind of drained out with no extra energy and sort of straight from the bottom of the barrel. So, being able to show up and be present and be ready for our patients is just as important, kind of on that emotional interpersonal level as it is showing up and knowing what they're there for and the purpose of it and kind of what the standard human protocols are. Again, when we're responding to kind of the effects of trauma, a lot of times we're trying to reestablish trust, right? Especially people that have experienced interpersonal traumas, abuse, neglect, assaults, things like that. So, we really want to work on establishing and maintaining a good relationship with people. So, being respectful, being clear, kind of what are the next steps? Here's what you can, expect from us. Being honest. If I say I'm going to call you in 2 days with some information, I need to call you in 2 days with that information, right? Otherwise, I told you I was going to do something and then I didn't follow through, and now I'm another untrustworthy person who wasn't mean, but like, yeah, I can't trust them. Just have to take care of myself. So if you say you'll do something, do it. If you don't think you can do it, don't say that you will do it. Say I'll try my best. Just set an expectation that the patient can understand and that you can live up to. Celebrate accomplishments, no matter how small. Sometimes just getting to the appointment was a big feat for that person, right? They had to get childcare, they had to take 2 buses, there was all kinds of stuff going on. Yeah, they didn't get their labs done. Okay, But hey, you made it here today, and that's something. So well done on that. Let's see what maybe if there's anything else we can do since you're here today to make time, and then we'll get you scheduled to come back when you get your labs done, right? But they got here today, hurrah for that, right? Little things like that sometimes can go a long way for people that aren't used to hearing any kind of praise or feeling good about themselves. And then same thing, focusing on the things they can do, setting up treatment plans on things that are reasonable, rather than focusing on the things that they didn't do or they can't do. Um, I'm still surprised sometimes when people prescribe insulin to patients who are homeless, kind of set them up for failure at that point and have to kind of go back to the medical department and go like, hey, this person doesn't like have a refrigerator or anywhere to keep insulin. Can we switch this to like metformin or something? And they're like, oh my gosh, I had no idea. So again, it's not even, purposeful sometimes. It's just everyone's hurrying and rushing. And so, being mindful of who is the patient in front of me and what context do they exist in. And if I'm going to help set up a treatment plan for them, what is it that's actually doable for that person that they can succeed at so that it's not another failure for that person because either it wasn't something they could do or like reasonably it just was maybe asking a bit much of them based on all the other things that they have going on in their life. So that's a lot. But if you need to remember something quick and easy, the 4 C's. Stay calm, right? Even if the patient's upset, model the behavior that you expect from the patient. It really does a lot. Again, your mirror neurons, their mirror neurons are going to follow what you're doing. So the calmer you can stay, the more they're actually going to reflect that back, and not you kind of both of you escalating each other up. Keeping the interaction emotionally contained, right? So keeping your own calm, but recognizing if you can't keep your calm, that you're going to step out and say, like, you know what, I feel like this is getting a little heated. I'm going to step out and come back in 10 minutes and we'll continue our conversation now, right? Recognizing maybe I'm having my own stuff going on. And so instead of letting this escalate to something, I'm going to maintain where we are and step out so that I can come back again with a little more reserve to kind of continue this interaction. Caring for the patient and caring for yourself, right? Being non-judgmental to the patient and to yourself. We all screw up, we all fail, patients and ourselves included. So again, what is that treatment plan? What is that expectation that I'm giving to the patient? What is the expectation I'm setting for the patient about what I or my office can do? And making sure that I'm, not committing too much myself that it's going to overexert me, or committing too much myself that I may not be able to follow through for my patient. And then focus on coping, right? Strengths-based approaches. What is it that they can do? What is it the things that they have done? The things that they are good at? What are the things that they are motivated for? What are the resources they do do? That can be a bit more of a conversation, but it goes back to building that relationship and building that trust with the patient that they feel like someone really cares, someone really sees me, someone's really trying to help me in a way that's actually helpful and not giving me things to do that I know I'll never be able to do because of my time and my resources or my tools. Um, you know, and also then also building into the patient that they have resilience, that they do have strength, that they do have positive attributes. And building on that over time really goes a long way to the patient feeling more confident, and more able to take care of themselves, and feel like the world is predictable, create some predictability in the world, because they realize they have maybe more agency now than they did before, or realize that they have more agency than they realize they even have right now. And so it can go a long way of that strengths-based, relationship-based, really seeing the patient for who they are and not just maybe the reaction they're having, in the long term, that really can build some successful and enriching relationships on both sides. So that was a lot. But take a moment right now and just think to yourself, like, how could you be more trauma informed in your daily practice, whether that's your practice at work or your practice at home, with your friends, with your family, with yourself? Are there things that maybe as I was talking, you're like, oh, I could do that. I could start asking that question that way, or I could, approach this maybe a little bit differently. Is there something that you're like, oh, I already do that? Great. And just maybe you can commit to continuing to do that or continuing to expand, that practice or that thing that you're doing that kind of feels like it's a good trauma-informed approach for you. Are there things that you really need to stop doing? Again, that you're not necessarily doing it out of spite or meanness, but maybe just the way you phrase something or the way you might word something, or maybe there is a policy that you have that, you know, um, it's really hard. Again, I work at an FQHC. We have, a lot, we work with a lot of communities that are very disenfranchised. Like we can't have a, if you're 10 minutes late, we can't be seen policy. Like no one would be seen because our patients, like the buses run late, the babysitter doesn't show up on time, they couldn't leave work when they were supposed to. Like there's all kinds of things that go on. And so part of our trauma informed practice was saying like we're going to expand that kind of no show time to 15 minutes, and even then it's a provider discretion because we want to give patients, like if they worked really hard to get here, we want them to be able to get something back. you know um, some of our patients, it takes an hour and a half to get here. And to say like, well, sorry, you were 10 minutes late, so now you can't be seen. You have to come back a different day. That's so defeating, you know. So if there's things like that, right, just to think about who is it that these policies are for, or how is it that we could approach different communities or our environment, right? Is my environment well lit? Is it welcoming? Does it feel nice to be in? Maybe there are some things that you'd like to change in the way that you approach, patient care or the way that you bring things that might help kind of those things be a little bit more prominent.
This is
And
really
then
nice.
ultimately,
Yeah,
again,
the way you talk about this as solution oriented, I really like. Um, and it also reminds me when you talk about this that we have to look back in our own past for our personal traumas. Because even though I consider myself incredibly lucky, I have had at least two traumas when I was young, well, three actually, and so I have certain triggers too, and there are certain things in my life that really bother me. So it's really important that I recognize my trauma and don't turn it into traumatizing other people because I could, and I have. Yeah. So,
again, yeah, again, we all have, and a lot of times, we may have triggers that we don't even realize we have, or we may just have worldviews that aren't necessarily triggered by anything. It's just how we see relationships or other people or the future or whatever that is. And it may just be like a constant, again, it's the lens that we view the world through about everything. So sometimes it's so kind of ingrained and kind of normal for what our life has been that we don't even realize that it's there.
yeah.
And that goes for patients as well. Like sometimes they're just like, this is just what life is. And it's like, this,
And even the medical system, it traumatizes all of us. Anyway, go on. I like this one.
yeah, well, I would say this is my penultimate slide. So again, I talk a lot, but if there's anything that you really take away from this, it's kind of, again, this principal idea of what trauma informed care is, which is kind of when we see kind of patient behaviors or patient reactions um, that aren't great, instead of kind of the typical, like, what is wrong with them? Like, what's up with them? To try to think of it as like, I wonder what happened to them that this feels like a helpful response. Like at some point, whatever it is they're doing was successful. That's why they keep doing it, right? And to say like, I wonder what they've been through that like screaming at someone was like the learned response for them to get their needs, because that must have been crazy. Like that must have been awful, right? If you know yelling at people is the only way they know to get their needs met. I wonder what where they like what their childhood must have been like, or where they come from. That's what they learned, and that's what their world was like, and that's how they keep just doing the thing they learned.
Yeah.
Um, so
Wonderful.
anyway,
Anybody have comments or questions?